Alright, so this is the recording for the chemotherapeutics lecture. So we'll start off with a couple of fairly easy multiple choice questions. Alright, so now we get to the characteristics of neoplastic or cancerous cells. So these are four main characteristics of cancer cells. So the first one is that they are persistent in their growth. So they keep on growing. And this is closely linked with the last quality here, the last characteristic of immortality. So immortality means that they don't ever die, right? Persistent proliferation, keep dividing, right? So they don't know when to stop. In fact, they don't stop. And this is also related to the second characteristic, invasive growth, which means that what they do is they break down barrier and they basically take over normal cells because they invade the territory of the basement membrane. They invade the territory of what normally other cells would occupy, and they basically take over those cells and the space that's occupied by those cells, and they basically make the organ or the tissue lose function. And then the third characteristic is the ability to form metastases. And you guys know what that is. That means that at some point, sometimes what can happen is that some of the cells basically break off and they travel usually via the lymphatic system, sometimes via the systemic circulation, and then they go to another location in the body, and then they form another cancer there. So that's what a metastasis is. Now, if you look at the diagram on the right, what you can see is that the growth rate of a cancer is actually fairly steep, right? And what you can see here is a cancer mass that weighs just 1 milligram has 1 million cancerous cells. Now, you can't detect a cancerous growth at 1 milligram weight. This is part of the subclinical. And then when it actually divides some more and grows and grows and grows until it becomes 1 gram, that's when the smallest detectable cancer is. But at 1 gram, the typical cancer contains 1 billion cells. And then anything upwards of 1 gram may lead to some alterations in normal function. So you have some early symptoms, and that's when diagnosis of the cancer can be made. And then at about this rate, then the growth rate slows down. So you can see here that the slope of the curve decreases. And then somewhere in between 1 gram and 1 kilogram, 1 kilogram is a lot of cancer, and it's usually when the cancerous mass becomes lethal because it takes over the surrounding tissue and impacts on the functioning of the person. And as you can see, as the cancer gets bigger and bigger, then the symptoms become more and more incapacitating. Now, one thing I want you to consider is that if cancer chemotherapy starts at around here, so maybe let's just pick a random number, maybe the tumor is detected when it's about 250 grams, a quarter of a kilogram, and you start cancer chemotherapy. And what happens with cancer chemotherapy is that obviously you want to kill the cancer cells, but the problem is that when the cells are killed, you have less and less cells. When it reaches somewhere around this level, what you have is you have a subclinical condition, right? Because it's too small to actually produce clinical symptoms, and you can't detect it, right? So it's undetectable. And it's really hard for doctors to actually find out, to determine when to actually stop treatment. So they make a best guesstimate effort. But what can happen is is you can actually leave some cancerous cells behind, right? Somewhere between 1 million to 1,000. And then over time, what happens is that condition, that cancer can actually come back. And that's when you have a recurrence of the cancer. So I thought I'd just show you this using this diagram. Possible benefits for chemotherapy, you all know this. First one is a complete cure. Second one is palliation, so just alleviation of the symptoms so that the patient becomes more comfortable and life isn't quite as debilitating. And then the third one is prolongation of a useful life. So even if the cancer is still there, the patient is able to function at a somewhat normal level and continue on with their life, whatever it may look like after chemotherapy. This slide actually shows you the cell cycle, and it's very important to actually know about the cell cycle because one of the things that you need to know is that the cell can either be resting, so it can either be in the G0 phase, or it can go through this cell division process, right? So when a cell is in the resting position, chemotherapy doesn't work, right? And sometimes cells can be in the G0 resting position, resting state for up to a few years, right? For days, months, years, where it's not really undergoing cell division, it's not growing, it's not doing anything, but it's immortal, right? So it's not going to die, but it's not actually being active at all. Now what happens is at some point in time, the G0 cells enters into a more active phase where you have mitosis, like a division of cell, and then you've got, prior to that, you've got synthesis of components needed for DNA synthesis. You have to make the DNA of the cell, and then you have to make the components for everything else, like the cytoplasm, the cell membrane, all the organelles, and all that kind of stuff. So that happens in the G2 phase. So G1, synthesis of components needed for DNA synthesis. S stage is the synthesis of DNA. G2 stage is the synthesis of things like cell membranes and organelles, like I said, smooth ER, rough ER, Golgi complex, mitochondria, and all that kind of stuff. And then the M phase is when the actual cell division happens. All right, so this whole thing here is the active stage, and this is where cancer chemotherapy can work. Now, there's this thing called a growth fraction, and the growth fraction is basically the number of cells in a tumor or a normal tissue that is in the G1 phase, so in the active phase, over the number of tissues that are resting. So basically it's the percentage, right? So we'll look at in the next few slides what a low growth fraction means and what a high growth fraction means and what kind of cells tend to be in the low versus high growth fraction. All right, so this is a slide. So low growth fraction, if a tissue is in a low growth fraction, has a low growth fraction, most of the cells are in the G0 stage. So the type of cancer that usually have a low growth fraction are solid cancers. And in terms of the response to cytotoxic drug, they basically have minimal response. Okay, so we'll look at in the next slide what happens with solid cancers, because you all know that sometimes solid cancers in the end include chemotherapy. All right, so let's just leave that now. And then cells with tissues with a high growth fraction basically have a lot of their cells in this active phase and just a few in the resting phase. So the type of cancer that typically have a high growth fraction are disseminated cancers. So these would be your leukemias, and your lymphomas. And also normal tissue with a high growth fraction are basically fast growing cells, like your hair, the lining of your digestive tract, your GI tract, and other fast growing cells, the mucous membrane, and all that kind of stuff. In terms of the response to cytotoxic drugs, they actually get a very good response. Okay, so it's these cancers that actually respond really well to cancer chemotherapy. All right, so we go on to here. So this is just an overview of the treatment of cancer cells. So you've got solid tumors versus disseminated tumors. So solid tumors are things like kidney tumors, adenomas, sarcomas, bone cancers, and all that kind of stuff, which are solid, right? So solid tumors basically tend to have low growth fraction. And because they're solid, what happens is they have poor vascularization at the core. So on the inside, the inner core of the tumor, there's not a lot of blood supply there, which is also another reason why cancer chemotherapy doesn't really work on solid tumors. So what happens is that surgery or radiation is used to get rid of the bulk of the solid tumor, and this is called a debulking procedure. And then after debulking, what happens is that the remainder of the cells basically enter the G1 phase and can respond to chemotherapy. All right, and that's how and why chemotherapy is usually given after surgery and or irradiation. Disseminated cancers have typically a high growth fraction, so they respond well to chemotherapy. And in terms of the chemotherapy, what we're going to talk about is we're just going to talk about cytotoxic drugs. So cyto, cell toxic, so drugs that are toxic to the cell. But there are other avenues for other sort of chemical treatment to combat cancer, such as hormonal therapy or immunotherapy. But we won't actually cover that in this lecture or in this course. Now, how does the specificity of the drug action affect the regimen, right? So what this slide is about is that some drugs basically act on one phase. So some drugs might act on the M phase. So you see over here, vinblastine and vincristine basically act on cells that are in this M phase, right? So they basically kill the cells over here, and cells that are in the G1, S, and G2 phase basically don't get affected at all. Okay, so what happens here is if you give drugs that are basically cell cycle phase specific, what you have to do is you either have to give it for a prolonged period of time, so prolonged infusion, or you give the patient multiple small doses at short intervals. And what happens when you do either of the two possibilities is that the first round, cells that are in the M phase will be killed. And then if it's a prolonged infusion or the next small dose, what happens is cells that were in the G2 phase will enter the M phase, and then that will get affected by the chemotherapeutic drugs. And then the next lot, in the next little while, cells that were in the S phase to begin with would have moved on to the G2 phase and then enter the M phase, and then the drug can actually kill it when the cells enter into the M phase. So you get the picture. So you have multiple small doses to actually target the cells when they get to the M phase or whichever phase the drug works at. Now, some drugs are non-phase specific. So basically, some drugs, assuming that the cells are not in the G0 resting phase, basically kill all cells that are active. Okay? And if that's the case, what happens is that you can get away with just giving a single bolus, right? A single dose. So what happens is with the non-phase specific drugs, you give it once, it affects cells that are in the M phase, G1 phase, S phase, and G2 phase. Okay, so that wipes it out all together at the same time. Now, that sounds easy, but obviously we all know that there are obstacles to successful chemotherapy. One of the things is that cytotoxic drugs, drugs that kill cells, basically are also toxic to normal cells. So the drugs do not have selective toxicity to only cancer cells, right? And that's why people's hairs fall out. They get mouth ulcers. They can't eat because the lining of the digestive tract isn't being renewed sufficiently, and all that kind of stuff. So fast-growing normal cells also get killed in the process. The second obstacle is that sometimes the cancer can develop a drug resistance, and sometimes this drug resistance can cross over to other drugs, right? So basically, if a cancer becomes drug resistant, then you have a potential for therapeutic failure, right? So if a cancer is resistant to vinblastine, as we talked about in the last slide, then vinblastine won't work, right? And it might mean that vincristine also won't work. So there's that obstacle. The third obstacle is that it is impossible to produce 100% cell kill rate. And that's some of that I've explained before, in that it's really hard to detect any cancer that is below 1 gram in size. But also what happens is that for any given dose, the drugs basically kill a constant percentage of cells. All right. So, for example, let's say we'll start with 1 billion cells, and the drugs will kill 99% of the cells. Right. So you have 1 billion cells. Give the person 1 dose of chemotherapy. 99% of them die. You're left with 1 million cells, or 10 million cells. And then you give another dose of the drug, 99% of the 10 million cells die, then you're left with 100,000 cells. And then you give another dose, you're left with 1,000 cells. You give another dose, you're left with, well, you get the picture, right? So even though it does work, it kills at a constant percentage so that there's always something remaining. And you can't actually detect when it gets to below a certain size, 1 gram, you can't actually detect that, and the symptoms also go away. So it's subclinical at that point. The other thing is that the drug dose, for it to be effective, must remain constant. And again, this is in an ideal world, regardless of the tolerance of the patient, right? So if the patient is going to be given cancer chemotherapy for a period of 3 months, they're not going to be as healthy and as robust at the end of the 3 months as they would be at the start. But the drug dose has to remain constant. So you've got that to consider as well. The third one is that the patient does not mount an immune response, especially at the higher mass, right? So the patient or the host isn't helping at all to get rid of the cancer. And then the last one is one that I alluded to before, is that the symptoms disappear long before 100% kill rate is achieved. All right, so those are some of the obstacles there. Some of the side effects are listed here. So myelosuppression basically means suppression of bone marrow production. And the bone marrow is responsible for producing white blood cells, platelets, and red blood cells, right? So in order to combat these side effects of myelosuppression, what happens is that a patient may be given IV antibiotics prophylactically, so just as a safeguard to ensure that they don't actually come down with an infection of any sort. To combat the decrease in platelet counts, thrombocytopenia, what happens is that the patient needs to avoid drugs that cause bleeding. So, you know, your warfarins, heparins, and all that kind of stuff. Try to avoid those if at all possible. And then in order to treat anemia, which is very important in the health and mental status of the patient, sometimes a transfusion is given, or else the hormone EPO, erythropoietin, is given to stimulate red blood cell production. Okay. Now, the other typical symptom that a patient can have is nausea and vomiting. And sometimes it can be moderate, sometimes it can be severe. And this symptom is due to the stimulation of the chemoreceptor trigger zone, which is basically in the base of the medulla. And what happens here is that the blood-brain barrier at that state and that location is fairly leaky, and so it can detect stuff that may be toxic to the body. So some ways to actually combat this side effect is to give the patient antiemetics, or and also to pre-treat the patient with antiemetics to ensure that the patient continues with the program, to ensure patient compliance, and also to make sure that the patient actually eats, right? Because if you're feeling nauseous and you're vomiting, you don't eat, and then you lose weight, and then that doesn't help in the whole scheme of things. Chemotherapy can also be teratogenic, so to cause birth defects and whatnot. So, and it can also cause irreversible male sterility. So, a possibility would be to bank sperm prior to the start of the cancer chemotherapy. The next one is renal injury. Because these the cytotoxic drugs are hard on the kidneys, because they can actually cause cell death in the kidneys itself. So a tactic to combat this would be to hydrate the patient, either through intravenous fluids or to tell the patient to actually drink lots of water, and then to flush out the cytotoxic drugs with diuretics. right? So hydrate and then cause the kidneys to flush them out with the use of diuretics. And then the other thing is local burning from infiltration of IVs right at the spot where the cytotoxic drug is administered. So one of the things that is maybe possible would be to put a PICC line straight so that it avoids the IV, and then it also avoids just having to find a vein every time chemotherapy is administered. Strategies for success. So one of the big things with cancer chemotherapy is, as we said, it also kills normal cells, right? So hair, GI tract, bone marrow, sperm-forming cells are some of the cells. Um, and so what happens is if the cytotoxic drugs are administered at regular times, the rationale is that it will, when it's administered, so this is the times of administration of the chemotherapy, um, it will kill both the healthy and the cancer cells, but the rationale is that once that's done, the normal cells have a chance to recover, and then when you give the other one, then they have a chance to recover again. Give the next dose, chance to recover. Give the fourth dose, then they have a chance to recover. And then the rationale again to the cancer cells is that the cancer cells won't grow as rapidly as the normal cells, and so it would decrease at a much, much greater rate than the normal cells. All right, so that's the theory behind giving cytotoxic drugs at intervals. The other thing for chemotherapy to work, to increase the effectiveness, is to give two or more drugs in combination. So combination chemotherapy. Generally, it's much more effective because what happens is if you choose your cytotoxic drugs carefully, it can suppress drug resistance because you don't have a big dose of any single drug. And because you are giving the patient different drugs, which hopefully works by different methods, it's sort of getting to the same thing from a lot of different angles and hopefully increasing the cancer kill rate. And if you choose your drugs carefully and you make sure that their toxic side effects don't overlap, then you reduce injury to normal cells. So we'll look at it in the next slide, how that works. So in choosing drugs, you want to choose drugs that have different mechanisms of action. So for example, if you go back to the cell cycle, you maybe want drugs that act on the M phase as well as drugs that act on the S phase, say, so that it acts in different way. And you also maybe want one drug that basically causes myelosuppression. But then your second drug, you want to choose something that does not cause myelosuppression, but maybe has a different kind of side effects, say, that causes peripheral neurotoxicity, right? So you have some myelosuppression and some neurotoxic effects, but you don't actually double up on the toxicities. And then the third quality of choosing drugs is that these drugs work well when used alone, right? So you want drugs that are effective so that when you combine them, they're twice as effective or they have a synergistic effect. So this is an example. So if you have cyclophosphamide, you can see anti-cancer effects is on its own is very good. Unfortunately, it leads to a decrease in white blood cells, but it has no effects on the nerve, right? And if you look at the second drug, vincristine, anti-cancer effects still very good as cyclophosphamide, has no effects on white blood cells, so white blood cell count is not affected by vincristine, but it causes peripheral neurotoxicity, right? So what happens when you combine the two of them is that the effectiveness of the two of them is additive, right? And it somewhat causes myelosuppression and somewhat causes neurotoxicity, but um, not overly so because they have minimally overlapping toxicity. So this slide and the next slide basically gives you 5 major classes of drugs. So these are the major classes. Both these drugs are non-specific, right? Cell phase non-specific. And what happens is, as I said before, it can be administered as a single bolus, so just a once-off thing. Toxic to cells with a high growth fraction, but also it can the cancer can actually develop resistance to that. The platinum-containing compound, cisplatin, carboplatin, oxaliplatin, is used mainly in ovarian testicular cancer and advanced bladder cancer. Causes nausea and vomiting like you will not believe. And so again, pre-treatment with an antiemetic is good to ensure patient compliance and make sure that the patient doesn't lose any more weight than they really have to. And because it's also causes renal toxicity, then you ask the patient to actually drink lots, or you give them IV fluids and then give them a diuretic to actually flush it out. So also so that the fluid doesn't build up within the system. And then this is a second slide with 3 other major classes of anti-cancer drugs. You've got anti-metabolites, anti-tumor antibiotics, and mitotic inhibitors. So anti-metabolites basically act at some phase. So because they're anti-metabolites, they disturb metabolic cell processes. So an example would be methotrexate, which is disruptive to cells that are in the S phase. And again, as I said before, because it only works on one phase, it's cell cycle phase specific, you have to give it for an extended time or multiple doses over time. Anti-tumor antibiotics interact with the DNA, always given IV due to poor GI absorption. And then the mitotic inhibitors, in its name, it acts on the mitosis phase or the M phase, right? So we've looked at vincristine before, which is neurotoxic but doesn't cause myelosuppression, and its related cousin vinblastine is the opposite, right? So vinblastine causes bone marrow suppression but doesn't actually affect the nerve. So vincristine and vinblastine are often used in combination chemotherapy. And then we finish off with a few more multiple choice questions. So I hope that you enjoy it, and I'll see you.